This program is brought to you by Emory University.
Good morning, everyone. Thank you all for joining us for Heart and Vascular Grand Rounds today. Today we have a very special speaker. It is a great honor and privilege to introduce him today. Dr. Gregg Fonarow kindly accepted our invitation to give us this Grand Rounds today. And as a matter of background, Dr. Gregg Fonarow is very hard to describe in few words. It may take a whole hour just to introduce him. But he is currently the Elliott Corday Professor of Cardiovascular Medicine and Science at UCLA. He serves as the director of the Amundsen UCLA Cardiomyopathy Center. He is the co-director of the UCLA Preventative Cardiology Program. He attained the rank of Professor of Medicine in the Giffen School of Medicine at UCLA in 2003. His research interests center on acute and chronic heart failure, preventative cardiology, quality of care, outcomes, and implementing treatment systems to improve clinical outcomes. Dr. Fonarow has published over 1,400 research studies and clinical trials in heart failure, disease management, preventative cardiology, and outcome research. Each year from 2014 to 2024, a span of 10 years, Dr. Fonarow has been selected by Clarivate for the list of highly cited researchers, which identifies the world's most influential contemporary researchers across 21 scientific fields with greatest numbers of published articles that received marks for exceptional impact. In 2015, he received a Clinical Research Forum Distinguished Clinical Achievement Award. In 2017, he received the AHA National Chairman's Award. In 2019, he received the Outstanding Lifetime Achievement Award from the AHA Quality and Care and Outcome Research Council. In 2020, he became a member of the Association of University Cardiologists. This is an organization that was founded in 1961 and is only limited to an active membership of 135 academic cardiologists who shape the course of research and training in cardiovascular disease from the United States. And they are elected by their peers, so a great achievement. In 2022, he was the recipient of the American Heart Association Gold Heart Award. I can still go on, and we are very honored and pleasured, and it's a pleasure of mine personally that he accepted our invitation. And the floor is yours. He will talk to us today about optimizing the quality of care and outcomes for heart failure. Dr. Fonarow, the floor is yours.
Thank you for that really kind introduction. I really appreciate the invitation to present. So I will be presenting on the optimal implementation of guideline-directed medical therapy for heart failure. Please note the disclosures at the bottom of this slide. As I think all of you are aware, heart failure remains a substantial challenge. There's 6.7 million in the United States, men and women with prevalent heart failure. There'll be over 1 million new cases of incident heart failure, but the mortality rate remains substantial. In fact, for total deaths, it's 425,000 heart failure-related deaths. This is approximately 43% of all cardiovascular deaths in the US. Most frequent reason why Medicare-aged individuals are hospitalized, with 1.2 million heart failure hospitalizations with a primary discharge diagnosis, another 3 to 4 million hospitalizations where heart failure is a secondary diagnosis, and a tremendous cost. Now, despite really substantial treatment advances, there still remain large number of eligible patients who are not receiving one or more of the evidence-based guideline-recommended heart failure therapies, and thus having clinical events that could have been prevented. And thus, I hope to show you over the course of the talk that greater therapeutic urgency and more effective implementation of our evidence-based therapies are needed. Here's data we generated from Get With The Guideline Heart Failure, individuals having an incident hospitalization for heart failure, and looking at what the median survival is compared to the median survival of adults of comparable age without heart failure. And you can see even for individuals aged 65 to 69 having heart failure, the median loss of survival was over 15 years. by having heart failure. And you can see this is true across ejection fraction groups. And even for individuals aged 90 and above, a 4-year loss of median survival. Certainly, we need to do everything we can to prevent heart failure from occurring. But in the time frame that this was studied, where certainly many therapies were available, we're still seeing this incredibly high mortality burden. Now, this is a little surprising when you think about it, because we actually have a number of evidence-based therapies that have been developed through remarkable discovery science, then ultimately tested in large-scale randomized clinical trials that not only make patients feel better, help keep them out of the hospital, have the power to reduce all-cause mortality. And these have been replicated in the trials. You can see the relative risk reduction achieved with these therapies. You can see it expressed as a number needed to treat to prevent a death over 36 months can be in the single digits. And beyond that benefit for survival, we also have meaningful reductions in hospitalization for heart failure. So you would think, over the time frame that these therapies got developed, tested in trials, recommended in national and international guidelines with class 1 national standard of care recommendations, that I should now show you how mortality rates for heart failure have fallen substantially. And what we see is when we look for specifically patients with heart failure with reduced EF, the 1, the 5, the 10-year mortality rates remain high. Yes, maybe temporarily there's been this slight improvement, but nothing near what we would have expected if those therapies demonstrated in trials to work and recommended highly in the national guidelines were actually being implemented. So despite the availability of these therapies for heart failure with reduced EF, morbidity and mortality in the time frame that they were class 1 recommended in the guidelines remains high. So how do we actually explain this? And the simple answer is, in setting after setting and study after study, the vast majority of eligible patients are not receiving the complete set of these therapies. This is data we generated from the CHAMP-HF registry. Notice the time frame. So we're going to be talking about therapies at a time point that they were class 1 recommended in the guidelines, FDA approved for that indication, and widely available. And these patients all had heart failure reduced EF. Any patient with a known contraindication to the medication or documented intolerance were removed from the denominator. These were 150 predominantly cardiology, but some primary care practices, over 3,000 patients, heart failure reduced EF. And what we see is it's not as if the patients are not being treated with any medications, but usually about 1 or 2 disease-modifying medications. In the case of this study, the most frequent regimen was an ACE inhibitor, ARB, and a beta blocker. But when we look at, say, the angiotensin receptor neprilysin inhibitor used in only 13% of patients, MRAs, despite being class 1 recommended in the guidelines for more than a decade before this study, only 33%. Now, when we look further at dosing, saw the vast majority of patients were on, for those medications that need titration, on the initial starting dose with no attempt for further up titration. So the vast majority had not been up titrated to guideline recommended doses as tolerated. And when we asked the simple question for triple therapy, how many were on all 3 classes and at target dose, it was a shocking 1% of these eligible patients. And that would be true of, again, considering intolerance true when we consider blood pressures, whether you pick a cutoff for systolic blood pressure above 110, above 120, and so forth. So these very large treatment gaps, and these have been shown in multiple settings across the US. But it's not just the US. This is data from Report-HF. This is heart failure reduced EF patients across 44 different countries. And we see the same kind of large treatment gaps with regards to even triple therapy in these patients in the time frame where these therapies were class 1 recommended in the guidelines. And this was true across low, middle, and high-income countries. So this is a global phenomenon. So what are the reasons for underutilization of these evidence-based therapies? So some of this may be gaps in knowledge and awareness, just not aware of what the guidelines actually say, but most of this has to do with lack of systems to ensure the effective implementation, getting the therapy to the right patient at the right time each and every time. As I will show you, therapeutic inertia, misassessment of what risk patients face, especially when there's just mild symptoms present, and insufficient urgency. Some of it may be that clinicians are thinking the study population and randomized clinical trials are too narrow, and the results of the trial may not apply to this patient in front of me that's older or has more comorbid conditions. So some of it may be, debates about real-world clinical effectiveness. There may be over concerns about side effects or adverse events, questions about safety. Some of this may reflect overt bias based on the patient's age, sex, race, ethnicity, or socioeconomic status. There may be some legitimate concerns about access, cost, and value. And then, of course, in our current healthcare system, there's often misalignment of financial incentives. There's no greater compensation that occurs for providing truly optimal therapy for patients than providing one that's entirely inadequate. What about this concept of inertia? So this is looking at patients in CHAMP-HF longitudinally over time. And what you can see in visit after visit after visit, even despite having ongoing symptoms, even despite remaining at risk, even with interceding hospitalizations, we see very little change in dose of any of the therapies. We see very little initiation of a class 1 recommended therapy the patient's not on in the absence of contraindications. So in the absence of this, no improvement in the use of or dosing of GDMT over the first 12 to 24 months. And you say, well, maybe the patients weren't seen back frequently enough to make these changes. But heart failure patients on average actually have 20 to 30 outpatient EMN visits per year. That's about 1.7 to 2.5 visits with the clinician per month. So these opportunities are going unfulfilled. This therapeutic inertia takes a hold. You're on one or two of these evidence-based meds, you're feeling a little better, even though your EF's low, and you remain at substantial risk for events. We'll just think about it for next visit. So this is from editorial we published in 2021 in JAMA about the conceptual risk of heart failure. And, once patients have been clinically stable and our outpatients haven't had recent hospitalizations, there's often this view that, it's mild, stable heart failure. Do we really need to add additional meds? So what we wanted to conceptualize here, compared to ASCVD and the level of annual risk that patients face, how do the guidelines term those patients? And you can see very high risk group in ASCVD is having an event risk from 5 to 7%, where the most intensive therapies, including injectable therapies, are recommended for ASCVD patients. But yet in heart failure, when we look at our risk, it is so much higher in the lowest relative risk patients you could possibly identify. So using that same ranking of terminology, we should identify these patients as extreme high risk. And of course, for our patients with recent hospitalization or worsened symptoms, very extreme high risk if we were going to be quantitative about how that risk reflects what truly is the risk of having a clinical event. So this current generalized lack of therapeutic urgency translates to this unfortunate cycle where clinical risk is underappreciated, medication changes are deferred, time is lavished, and patients die or require hospitalizations without receiving the therapies proven to prevent these events. We could do so much better. But there's something else that's actually reflected here. I think a lot of clinicians, without overtly thinking about it, have a general impression that maybe there's some diminished returns, that once we get one or two meds on board, that absolute and relative benefits of adding a third or fourth medication somehow overlapping or redundant. So what has truly been demonstrated, the effects of adding one GDMT to another? Clinical care is reflecting a view that, once you're on one or two, you're pretty much done, and three and four are optional. So it's either subtractive, redundant, or only partially additive. So do we have evidence that these medications are truly additive to each other, in some cases even possibly synergistic? Then in case of angiotensin receptor neprilysin inhibitor, beta blocker, MRA, SGLT2 inhibitors. These are truly non-overlapping, truly additive, truly cumulative benefit, that 1 + 1 + 1 truly equals 4, to where it's worth the time, the effort, and expense to get patients on all of the medications that are class 1 recommended in the guidelines. So let's go through briefly some of that evidence on whether the benefits are truly additive and what that magnitude of benefit is. So if we go back to some of our original trials, ACE inhibitors versus placebo in heart failure when background therapy was largely just loop diuretics and digoxin. And what we can see is these agents not just made patients feel better, improve hemodynamics, reduce hospitalizations, but have the power to reduce not just cause-specific, but all-cause mortality on the order of about 16 to 20% relative risk reduction. Now, our next class of medications that were added on a high background rate of ACE inhibitor or ARB therapy, you can see the rates well in the mid 90%. Beta blockers in study after study provided an incremental, truly additive, truly cumulative mortality benefit that was even larger, on the order of a 34 to 35% relative risk reduction in all-cause mortality. Clearly, in this case, ACE inhibitor plus beta blocker 1 + 1 equal 2 as far as magnitude of benefit. Now, what about the aldosterone antagonist and mineralocorticoid receptor antagonist? In the RAWS trial, vast majority were on ACE or ARB therapy, but relatively few on beta blockers, given this trial was completed in 1999, a very large additive mortality benefit. But in emphasis HF, done a little later, and including mild heart failure, now a high rate of ACE inhibitor and ARB use and beta blocker use, and we see the additive benefit not just for its primary composite endpoint, but for all-cause mortality. So clearly here, 1 + 1 + 1 was equaling 3 in triple therapy odds, truly incremental and cumulative and large relative additional risk reduction and absolute risk reduction. Now, with our next evidence-based guideline recommended therapy, this is sacubitril/valsartan, and looking at the addition of neprilysin inhibition. But since this had to be coupled to ARB therapy rather than compared to placebo, it was neprilysin inhibition with an ARB compared to a gold standard ACE inhibitor, but importantly, on a high background rate of beta blockers and high background rate of MRAs. So this is that incremental benefit of a fourth mechanism now of neprilysin inhibition. And you can see for the primary composite endpoint for CV death and even for all-cause mortality, this incremental benefit of neprilysin inhibition. So now establishing therapy of sacubitril/valsartan, evidence-based beta blocker, and MRA having truly additive and incremental benefits. So we can see here actually the type of cardiovascular or all-cause mortality reduction we could get with an ARB or ACE inhibitor could be doubled up with that addition of the neprilysin inhibition, again on a background of beta blocker and MRA therapy. Now, also very important, and in each of the trials, I'm just going to show you here from Paradigm, but every one of the trials I showed you before, when you try to look at whether this was a specific or personalized or precision effect or a population benefit, what we find is no heterogeneity of effect by demographics, by background therapy, by comorbidities. Across 46 pre-specified subgroups, you could not find a patient that was better off on the ACE inhibitor than on sacubitril/valsartan. No heterogeneity of effects for the primary composite endpoint or for cardiovascular death in that regard. So it truly, for heart failure reduced EF, population-wide benefit with regards to applying therapy. So the next drugs that were added to our list of guideline-directed medical therapies, the SGLT2 inhibitor, originally discovered for type 2 diabetes, but this remarkable finding in the safety study of less heart failure hospitalizations and heart failure death, raising the concept these could be a therapy for patients with heart failure reduced EF, irrespective of whether they had type 2 diabetes. The DAPA-HF studied this, dapagliflozin 10 milligrams versus matching placebo on a high background rate of other guideline-directed medical therapy and for a primary composite endpoint. And what you can see for the primary endpoint of CV death or a heart failure event, 26% relative risk reduction, an NT of 21 on a high background rate of RAS inhibitor, sacubitril valsartan, beta blocker, and MRA. So now truly additive effects here where all four therapies providing incremental, truly additive benefit. This was true whether patients had type 2 diabetes or not, no interaction whatsoever. This was true across any background therapy and truly additive to sacubitril valsartan. And this was true across all clinically relevant subgroups. What was also remarkable was the safety here. You think, oh, giving a drug developed for type 2 diabetes to those without type 2 diabetes, there'd be some effects like hypoglycemia or renal effects or otherwise. And we see overall was well tolerated as placebo, and for side effects of specific interest, no difference with regards to the placebo rate. And diabetic-related ketoacidosis, incredibly small, 0.3% in those with type 2 diabetes and 0% with dapagliflozin in those without. This finding was replicated in Emperor Reduced. Look at how incredibly comparable the outcome risk reduction was here when pulled into this meta-analysis published in Lancet. You see the incremental benefits and importantly, for all-cause mortality, and again, additive to the other therapies and across all of the pre-specified clinically relevant subgroups. So I think we clearly have this data that establishes that these therapies are truly additive, that the magnitude of relative and absolute risk reduction as illustrated here are clinically relevant and profound. If all evidence-based medical therapies are used compared to no background therapy over a 2-year risk in patients, this is a relative risk reduction of 74%, an absolute risk reduction for 24-month mortality of 26%, and the number needed to treat to save a life with this quadruple therapy is an NNT below 4. So with this magnitude of benefit, and from every standpoint, the individual patient, the individual clinician, the individual health system, the community, nation, and globally, why would we not want patients to derive this magnitude of benefit with drugs that are safe and well tolerated? So the next question becomes, how should we actually implement this and effectively into practice? And should we follow the sequencing and initiation of these meds that were utilized in their discovery and how the clinical trials were conducted? In other words, most clinicians in thinking about how to actually adopt these into clinical practice sort of followed this serial and historic sequencing strategy without really giving it much thought. But starting off with ACE inhibitor A or B, and then up titrating at 2 to 4 week intervals is tolerated. And then once achieving that full dose of the ACE inhibitor A or B, then adding the beta blocker, the low starting dose, and going through its up titration, and only then when on both therapies, then add the MRA and start at a lower dose for safety and monitoring, and then up titrate, and only then think about switching to sacubitril valsartan and up titrating then, and then and only then add the SGLT2 inhibitor. So if you map this out, it would be 28 to 56 weeks till GDMT was fully implemented. But that's in the perfect world where every step is followed and every follow-up visit is completed and there is no therapeutic inertia. But as I showed you, after 1 or 2 drugs, everything stalls out and none of this actually takes place. And that's what we see in clinical practice. The other question is, even if you have the perfect implementation system, do we have the time to actually, delay therapy this long before being on the full set of GDMT? So the key question is then, how rapidly do these drugs have effects, and can we afford to wait? What's the timing of GDMT benefit? And what has been remarkable and largely overlooked in the early evidence base is how incredibly early the benefits are actually realized. In Copernicus, with more advanced heart failure, patients started on carvedilol. Within 2 weeks, the survival curves are diverged. The risk of worsening heart failure in the first 8 weeks substantially lower with initiating the beta blocker early versus delaying the 8 weeks. When we look at the use of MRAs, it wasn't highlighted when the trials were published, but these event curves diverge very early. In fact, within about 19 days, there was already clinically relevant and statistically significant risk reductions by 30 days, highly statistically significant across each of these trials. So rapid benefits as far as preventing hospitalizations and reducing mortality. Now, with sacubitril valsartan, early benefits were seen in Paradigm HF, but it had a run-in phase. That question of, with de novo initiation of hospitalized patients, that was tested in Pioneer HF. Of course, by the time this study was done, the guidelines would say within 8 weeks, patients still with symptoms should be on sacubitril valsartan. So this was just an 8-week trial. But looking at starting off at sacubitril valsartan versus going with an ACE inhibitor the first 8 weeks, and then patients would be switched over. What they found, the primary endpoint was N-terminal BNP, but for clinical events of CV death and rehospitalization for heart failure, an endpoint that you never thought you'd see with a trial this small, actually had a 42% reduction in risk, a 6% absolute risk reduction, and highly
and I'm like, they're fucking like, I'm like, but
so
wait,
you
my
can
daughter's
really
like,
see
I'm like,
substantial benefit here.
Like, how can
If we look at de novo patients in this trial, so those worsened with chronic heart failure versus de novo, we really see the same type of benefit. So delaying sacubitril valsartan by even 8 weeks and starting with an ACE inhibitor ARB first clearly is causing events for the patients we can't subsequently make up and becomes the standard of care. So what about the timing of SGLT2 inhibitor benefit? This is remarkable. In DAPA-HF, within 1 day, the hazard ratio was lower. By day 28, this was statistically significant, was actually a 49% reduction in risk, then maintained through the first 100 days and the rest of the trial. You can see with the SOLOIST trial in acute heart failure starting sotagliflozin in hospital or very shortly after discharge, a 39% reduction in events by day 28, and that reached statistical significance. For Emperor Reduced, the first time they checked health status at 4 weeks, there was already this tremendous separation. And we see in the MPulse trial and recently in the DAPA-ACT trial, these early benefit with early in-hospital initiation here in hospitalized patients in the first 24 hours. So this remarkable early benefit with SGLT2 inhibitors. So with all of that data of early, remarkable, additive benefit, what about the concept then that we first put forth in 2020 of starting in eligible patients newly diagnosed with heart failure, reduced EF, all 4 of these guideline recommended therapies in very rapid sequence or simultaneously at the low starting dose. Subsequent data will show you safe, well tolerated. Conceptually, you're getting the benefits within days for all 4 of the meds cumulatively. The priority is then the up-titration of beta blockers that have the steepest dose response curve, sacubitril valsartan, subsequent up-titration, 1 adjustment of the MRA, SGLT2 inhibitor, no up-titration. And this means by day 21, you could be on full optimized GDMT quadruple therapy. Then focus on maintenance, whether additional therapies should be considered. By doing this, it's estimated to be a greater than 75% risk reduction in that first 30 days. It overcomes clinical inertia because by day one, you're on all 4 of the meds. And this potentially allows us to more effectively, more rapidly implement the full contingent of therapy. So what are the potential benefits of this approach versus historic drawn-out sequencing? The rapid improvement in health status, rapid improvement in EF, such that many patients will get up above 35%, no longer need, benefit for, or qualify for device therapy. They're the rapid reduction in hospitalization. Who wouldn't want a reduction in your hospital's risk standardized readmission rates with Medicare penalties? There is the rapid reduction in mortality. And importantly, you overcome therapeutic inertia. And as I will show you, there is strong data that you improve adherence, persistence with this type of approach to therapy. Now, a concern, of course, is, well, wait, you start off 4 of those meds at once and patients are going to have symptomatic hypotension or worse. This sounds like a horrible idea from a practical standpoint. But if you actually look at each and every one of these 4 classes of meds, when starting at the initial low starting dose, that the tolerability of these meds as far as blood pressure is actually quite excellent. Yes, in people who are overtly hypertensive, there is some lowering of blood pressure, but those with blood pressures in that 85 to 95 range, if anything, you see either no change in their blood pressure or it going up in the case of beta blockers. There can be a little more symptomatic hypertension with sacubitril/valsartan, but that tends to be braked in those. And then with MRAs, you see almost no effect in those with lower starting blood pressures, and the same thing with SGLT2 inhibitors. So we're talking at most 1 or 2 millimeters of systolic blood pressure, so long as the patient is not over diurese. Now, on the perception of side effects, many people would say, well, if I start out 4 meds and the patient develops a side effect, I won't know which medication it is. Well, this is pretty interesting because when we look back at our randomized controlled trials at medication attributable adverse events, where patient and or the study physician is saying, we started this drug, this side effect is due to the medication. It's a treatment emergent adverse event. But when we looked at these studies, it's pretty interesting. It is just as likely to be placebo with all of our classes of GDMT, meaning it was due to the patient's underlying heart failure or their comorbid conditions and not specifically related to that GDMT being started in a double-blind fashion. So in fact, by starting these therapies early, we're enhancing their tolerability, reducing the progression of heart failure, in some cases, treating comorbidities. In many cases, we're going to make adverse events less likely. In most cases, we know the profile well, and if there truly is an adverse effect, we can figure out which drug it is that we need to make adjustments. Now, what about this issue about representation in the trials? I mean, are the trials really reflecting the older patients I see in clinical practice? Or more recent trials have actually been representative with large numbers of patients, about 65, about 75 in their 80s. And what we see is the relative risk reduction is as large. Older patients at higher risk, so the absolute risk reduction is greater. And in fact, the tolerability is largely comparable. So in older patients, heart failure reduced EF, the benefits are greatly exceeding the risk. And in fact, if we look at real-world clinical effectiveness, this work we generated with Get With Guideline Heart Failure, look at the median age of these patients treated with beta blockers, ARNI, MRA. We have recent data with SGLT2 inhibitors. Despite their age, comorbid conditions, frailty, we're seeing clearly better outcomes among those treated than comparable patients without contraindications not treated. So real-world clinical effectiveness and safety. Well, what about polypharmacy, right? We've all heard that those patients with heart failure are on a multitude of medications. The more medications they're on, the worse the clinical outcome. Polypharmacy is bad and best avoided. Well, I think we need to distinguish between polypharmacy of GDMT versus polypharmacy of drugs that don't enhance quality of life, don't improve symptoms, and may worsen heart failure. It is true, the number of unique medications you're on at randomization in trials, the higher the number there are, the worse the outcome. But it's a marker for the underlying comorbidities. Because if adding an additional medication to the higher number of meds is associated with better outcomes, that's clearly proof, and that's exactly what we see. The more unique medications you're on at randomization, the greater the relative risk reduction of our guideline-directed medical therapy, and this has been seen in study after study. So does polypharmacy alter the safety and efficacy of the evidence-based heart failure therapies? No, if anything, it enhances it. So that is not a reason to utilize it. Certainly a reason to get rid of meds that don't improve clinical outcomes, but not for these. We also have a lot of data where when patients come in or hospitalized and without an absolute contraindication, one or more medications get held, there's a little bump in creatinine or otherwise. Does that cause harm? Because often they get discharged without it and doesn't get restarted. And study after study is showing, compared to continuation or initiation, that withdrawal in the absence of contraindications are associated with worse outcome in real-world clinical practice. So you may say, well, that's all well and good, but where's an actual study where you try this really intensive strategy of starting multiple meds at once in patients and show, it's not going to cause extreme harm and may have benefit. And in fact, we do have a trial that is strong HF. This was done in the era of triple therapy. And these patients were randomized to usual care, hospitalized with heart failure, not on optimal treatment, versus high intensity care, starting multiple meds in hospital, achieving at least 50% of target dose prior to hospital discharge. So we're talking multiple initiations, up titration steps in the course of a short hospitalization, seeing the patient back at a week, assessing safety, doing further up titration, by 2 weeks being done on optimal doses as tolerated, the full set of meds, and then followed out to 90 and 180 days versus usual care. Start what meds you want in the hospital, up titrate as you would as an outpatient. Study stopped early by DSMB due to overwhelming benefit. So what happened in usual care with meds? Exactly what I showed you. Like, nobody was started, nobody was up titrated through 180 days for the most part. You can see in the high intensity arm, not 100%, but for full optimal dose, more than half of patients, and on some dose, the vast majority of patients. So what happened with regards to tolerability? So there were some modest changes in blood pressure. Potassium went up by only about 0.15. GFR went down, but not statistically significant. And you can see that, in fact, for congestion, it got substantially better. New York Heart Class got better. Prognostic biomarker got dramatically better. So safe, well-tolerated patients felt better. And importantly, for the primary endpoint, readmission for heart failure, all-cause death, this 8.1% absolute risk reduction, this 34% relative risk reduction. Again, this isn't compared to no therapy or placebo. This is compared to usual care, this rapid intensive approach to GDMT and quality of life improving. Now you may say, well, how many of our patients with new onset heart failure reduced EF are actually eligible for quadruple therapy? So we systematically studied this and get with the guidelines. So these are all comers, not requiring informed consent, not selective outpatients, all comers with heart failure with reduced EF, and then looking at eligible for quadruple therapy, and you can see that's 82%. And for eligible for triple therapy, it was about 93%. Now, what percentage of these eligible patients were actually at this time being treated in clinical practice? Quadruple therapy, only 15.3%, triple therapy, only 42%. And that is with, our estimates of what this would mean compared to being on no GDMT, being on what the most common regimen was, ACE inhibitor, ARB, and beta blocker, and quadruple therapy. You can see, 25% compared to no therapy, but, still getting an absolute difference where you're getting about an additional 10% incremental reduction in mortality with quadruple therapy compared to double therapy in just the first 12 months. So here's some tips for optimal titration: paying close attention to volume status, checking orthostatic vital signs. If need be, can stagger the dosing, emphasis on the medication adherence, and addressing any cost barriers. And importantly, if you don't start all the meds at once, you need to highlight that any additional therapy is about improving heart function and prognosis, not an indicator of the patient getting worse or that the other meds didn't work. So this was from a recent review we published in Circulation of kind of the 5 core principles of GDMT, but highlighting, the benefits of that rapid initiation, rapid dose up titration, and this benefit. Here we highlight beyond that low NNT that compared to no therapy, you can extend the median survival for your patients with these 4 once or twice daily medications 7 to 11 years. Think if this were oncology, what we're talking about here, where often drugs that extend median survival by 6 months are celebrated as absolutely phenomenal breakthrough. There's also a risk treatment paradox where those older patients, more frail, who would derive the greatest absolute benefit are less likely to be treated. And of course, the benefits, as I highlighted to you, outweigh the potential risks. So, every time we're seeing patients, we have this opportunity, where there are the risks to commission. We could start a med and they have adverse events and side effects that get attributed to the drug, even though less likely to actually be the drug. But there's the potential harm of delay or not trying, of decreased survival, increased hospitalizations, reduced quality of life, and increased symptoms. So every visit, every setting, new onset heart failure is not low risk, a stable outpatient heart failure, not low risk, hospitalized heart failure, not low risk. Every one of these, we should be aware of the risk of omission and overcoming this. So the side effects and harm of lack of initiation, titration, or persistence of our GDMT are documented here. So, if we think about it like that, it becomes, far less likely we're going to say, oh, let's divert therapy till the next visit. So the magnitude of benefit for mortality reductions highlighted here. Also, look at the absolute risk reduction for heart failure hospitalization risk, 85% relative risk and 33% absolute risk reduction. So all the guidelines have embraced this. So the C guidelines, the guidelines from the AHA/ACC, the 2023 update of the ASC guidelines now has a class 1 standard of care recommendation for the intensive strategy of initiation and rapid up titration of foundational GDMT therapy. The 2022 guidelines, class 1 level of evidence A for ARNI, evidence-based beta blocker, MRA, and SGLT2 inhibitor. Why some clinicians look at it as if it's a menu, I'll pick my favorite 1 or 2 off the list. The guidelines are explicit about all 4 of the therapies being utilized in the absence of contraindications or intolerance. There clearly are some other therapies that are not foundational that in select patients may be added. There's some newer data with regards to vericiguat that may change this level of recommendation. Our treatment pathways have now embraced this quadruple therapy upfront. This from the ACC in 2024. So, what's the harm of delaying a few of these therapies to outpatient? Well, study after study has shown you're about 85% less likely to be treated at 1 year if you don't start in the hospital than if you do. So unfortunately, in heart failure, go slow means rarely initiate. Whereas in hospital initiation, more likely to be treated, more likely to tolerate, more likely to persist, adhere, be able to stay at home, and more likely to survive. The guidelines give a class 1 recommendation for GDMT during hospitalization being initiated and optimized. Other strategies to facilitate GDMT initiation are highlighted here. I talked about in-hospital initiation, the rapid simultaneous approach, multidisciplinary heart failure disease management teams. There is evidence for GDMT clinics, digital health systems, and others. So here's data from Get With the Guideline Heart Failure and Improve HF, where performance improvement systems can rapidly and simultaneously help improve the use of GDMT. This is from Titrate HF using this approach of quadruple therapy initiation, safe, well tolerated, and far more patients treated, and improvements in ejection fraction and clinical status on a large scale for de novo heart failure. This is from an outpatient GDMT clinic where patients were not on quadruple therapy and where advanced practice nurses and PharmDs, under the supervision of cardiologists, but not actually seeing cardiologists, were up titrated on these meds, were able to get over 90% of patients on GDMT. During the same time period, treated in one of the best and most revered healthcare systems in the US by cardiologists, look at usual care changes in these meds. And this study was done just 2 years ago. So, we're looking at dramatic improvements with the focused treatment strategy, health status improved. This is Implement HF, 100 hospitals working with the AHA, who started off baseline use of quadruple therapy at discharge and at 30 days shown there. You can see very rapidly getting this to increase, almost 7-fold up to 50%. The most recent data were up to about 65% quadruple therapy for Get With the Guideline heart failure participating hospitals. We now have some evolving data with regards to heart failure with mildly reduced and preserved EF, where the composite of cardiovascular death and heart failure hospitalizations can be reduced. There's clinical event reductions here with the GLP-1s, data with non-steroidal MRAs, and with SGLT2 inhibitors. So what about a similar approach here? So we recently published on this the concept of taking the 3 pillars of what is now heart failure with ejection fractions above 40%, SGLT2 inhibitors, MRA, and for those who are overweight and obese, GLP-1 receptor agonists, and starting these therapies rapid sequence or simultaneous, focus on their up titration. Could we achieve benefit with this type of approach? And so, now across the spectrum of EF, we have this growing contingent of evidence-based therapies we can apply to improve clinical outcome. So we're really at a point where if we were defining high quality care and employing a key heart failure performance measure, as we just published last week, that we could have heart failure with reduced EF, not just did you end up on the 4 pillars of GDMT, but actually the time to achieve that and the time for optimal dose, and perhaps something parallel, time to 3 pillars for our heart failure with EFs greater than 40%. So really thinking it's not just ultimately what meds we get the patient on, but proceeding rapidly and with precision around the early benefits that these therapies offer. Now, I recognize, seeing this may make some people wonder about, is this really practical from an access and cost effectiveness standpoint? Now, by our formal cost effectiveness, studies, even at full branded prices, these drugs were, proven to be cost effective. But, what's really most important here is access and out-of-pocket costs for the patients. And there were challenges with regards to SGLT2 inhibitors and sacubitril valsartan in that regard. Now, the guidelines say, look, they're cost effective. When we formally analyzed quadruple therapy, we showed it was of incredibly high value. But again, it still comes back, even if you're, incremental cost effectiveness ratios below $50,000 per quality adjusted life saved, what does that truly mean for a patient who can't afford the out-of-pocket expense? But we've now just entered the era where this is not an issue for any patient under your care in the US. This is the cost of these drugs with no insurance, straight out of the pocket, cash pay price. Why? Because sacubitril valsartan, as of last month, has become generic and is widely available. You've got prescription drug coverage, great. It'll be covered at a low generic price. But if you don't, you can get this directly from Cost Plus. Evidence-based beta blocker, MRA, incredibly low costs. Now, certainly DAPA and empagliflozin may be preferred, but bexigliflozin is an SGLT2 inhibitor that does have some outcome data, and you can get this for a cash price of below $50 a month. So total quadruple therapy out-of-pocket cost, even in the absence of insurance, is $125. For those with Medicare Part D, they can get all of these. Their maximal cost for all meds, no matter what branded meds they're on, 50 meds, the maximal out-of-pocket expense in 2025 is just $2,000 or $167 a month. So we've now entered an era where cost, financial toxicity should not be an issue. The financial toxicity, by not applying these therapies, you're exposing the patients to an average cost of $5,000 a year and their insurer for just the hospitalizations that could have been prevented had these therapies been applied. What does this mean for median survival? Well, compared to being on double therapy, using quadruple therapy, we can extend our patient's life by 6.3 years. Does this work in real-world practice? Following the guidelines, we've been able to show, what we would expect, that, 75, 80% reduction mortality actually occurs in real-world clinical practice. For every 10% improvement in heart failure guideline concordant care, we get a 13% relative risk reduction in 24-month mortality. So I'll leave you with this thought as we wrap up. If we look at our randomized clinical trials of the last 20 years in heart failure, not in the intervention group, but the placebo group, there's been this remarkable reduction in cardiovascular and all-cause mortality. Say, well, why is that? Well, to get in the trial by protocol, you have to be on the guideline recommended standard of background medical therapy. But in clinical practice, in the same time frame, in the real world, this from Olmsted County, you have heart failure reduced EF, survival barely changed. Why? Because in clinical practice, clinicians can do exactly what they want. Nobody looking over their shoulder, no performance measures on whether these therapies were actually applied into clinical practice, and there's huge gaps in variation. If we used a more protocolized approach, as done in clinical trials, you can imagine what the kind of magnitude of benefit would be. You think, maybe this is a little questionable. Here's data from CDC Wonder that we looked at. There was progress being made, but in about 2012, this stalled out. And what we then see is when we look at age-adjusted mortality trends, back in 2021, there's a little COVID effect here. It was where we were back in 1999, maybe even a little worse, and across demographic groups. Sure, some of this is more heart failure occurring, but some of this is our patients, once they develop incident heart failure, not deriving the true benefits at the population level that they could achieve. So the magnitude of benefit is profound, and there's no good clinical justification. The absence of contraindications or intolerance for not applying each of these therapies. Clearly, a 9.5% mortality risk at 2 years still too high. We need further research and other incremental therapy, but compelling data why we should make every effort to apply these therapies in every setting to every patient. So what would happen if nationwide we quantitated current rates, optimal rates of treatment, and what the lives could be saved? Close to $100,000, and we recently did this globally, looking at the rates of treatment across the world, and if there were truly optimal implementation of quadruple GDMT for the 29 million individuals estimated to have heart failure reduced EF, this would translate to 1.2 million potential lives saved per year globally. I think a compelling reason for why an individual patient, every health system, every country, and globally, we should be working to achieve this. So our approach to heart failure medications, think I hopefully have shown you compelling evidence that these medications are truly additive and incremental. There is no substantial overlap demonstrated for quadruple therapy. The optimal approach is to utilize each of these medications to reduce all-cause mortality in combination, so long as not contraindicated or not tolerated, and start each without delay. A serial or selective approach, unfortunately, leads to delays and events that could have been prevented with earlier implementation. These therapies provide high economic, but most importantly, high clinical value, and the implementation of GDMT needs to improve in each and every clinical setting. Thank you so much for your attention today.
Thank you very much. This was absolutely fantastic. Very elegant talk and, very compelling data. I'm going to open it to the audience for questions. And please, if you can't unmute, please, you can enter your questions in the chat and I'll make sure that we will read them. But while people are putting in their questions or putting them in the chat or preparing them, I have a comment, and actually you touched upon it a little bit, and I've also seen this international trend of complacency, as to say, in guideline-directed medical therapy implementation in heart failure, and usually the three common causes, as to say, that people are a little hesitant for this is, number one, cost. And now, surprisingly, independent of the healthcare system they work in, sometimes these medications are almost for free, but still they are worried about that. Number two is side effects, as you touched upon, and number three, intolerability. What do you think of the cause of that? I know you mentioned few risk factors there. However, I have a theory, and I'm curious to see what your thoughts are.
So it's multifactorial and may depend, but it's a really insightful comment. But one of the things I'll say is, if you think about how, in most cases, these therapies are introduced, there's not an explanation as that patient's diagnosed, here are these 4 key therapies. These all are additive and are going to provide this magnitude of benefit to you. It's like, oh, we're starting these 1 or 2 medications, and now, oh, you need this next one. And the patient's thinking, wait, why? Were the first 2 not working? It's weeks later. What are the side effects are going to be? Does this mean I'm getting worse? Does this mean I failed in some way? I mean, it's setting up this misperception about the medication, successfully making them better, reducing the risks, improving their health status. So having that patient on board, as opposed to when we're starting these meds up front and are explaining they work well in combination, this is why we're starting them, the attribution with regards to what is being thought, and even when you're starting placebo, you see a lot of these effects. So this perception issue, certainly hospitalization is a teachable moment. They wouldn't let me out of the hospital without 1 or more of the meds. The fact they let me out and now you're starting it later sets up all of these connotations. Plus, I was getting in the hospital, this nice nurse gave it to her, I was on the monitor, they checked my blood, clearly I'm tolerating, versus outpatient. You start the meds, you go to the pharmacy, they give you this long list of these horrible side effects that nobody talked to you about previously. You're like, is this going to happen to me? And scary, take it at home. What if something happens? So there's a lot that works, against and creates a perception against those medications started in this drawn out serial approach. Can be overcome with advanced practice nurses and all that kind of support, and perhaps digital strategies and AI-based education and otherwise. But there's a lot working against you than when you start those medications up front.
Yeah, I agree. I think that's like you said. I think a lot of has to do with that, and I've seen it in my clinic actually. When the response to patients is really different from the way you approach implementing these medications. And I also think that there's a system implementation issue too. I mean, if we contrast ourselves to the oncology world, that's kind of very, very evident that there's a system in the oncology world versus us is just, but we are trying to achieve that.
I'll say one other comment. Why in oncology is there not this issue of not having rapid uptake of some of the most expensive and new therapies? And that is there a strong financial incentive. Now, there's a rationale for that incentive to overcome inertia, to overcome any cost or barriers to access to stock those medications to administer in the oncology practice or infusion center. And that plays out in some ways a favorable way of the rapid uptake of the newer therapies into practice. Whereas in cardiology, all the disincentives are around that you're going to get, extra calls, there's prior authorization, and often clinicians will default to a more lackadaisical strategy. But the cost and access issue for quadruple therapy has really now, as of this month, has been essentially eliminated. So even if you were operating under, wow, it was really challenging before, change that stance because there's already access now.
Thank you. Any questions from the audience? I do see a question from I think that's Dr. David Vadney. What are the outcome differences using 4-drug GDMT with heart failure with mild reduced EF and HFpEF compared to HFrEF?
Yeah, it's a great question. So certainly two of the drugs overlap, right? So the MRAs and the SGLT2 inhibitors for hospitalization reductions are really comparable. All-cause mortality reduction when the EF's above 40%, in part due to competing risks of non-cardiovascular mortality. It's been more difficult to demonstrate the risk reduction in cardiovascular death and all-cause mortality. So there is distinguishment there. The magnitude of hospitalization reduction is very comparable. The GLP-1s predominantly so far have been the reduction in heart failure hospitalizations in that regard and some atherothrombotic events rather than mortality. So we can very much match the benefit there. For mortality reduction in mildly reduced and preserved EF, we'll need some additional benefit. And then particularly heart failure preserved EF, we don't have the kind of data for beta blockers. Some of the data would say maybe we're making patients symptomatically worse. For heart outcomes, we really don't know. They've been underrepresented in any of the trials. And so we really need some randomized clinical trials there to know where that EF ideal is for beta blockers. Whereas, for the others, sacubitril valsartan really, once the EF gets above 50, 55, starts to fade out in the benefit that it's offering the patient.
I have a question.
Yes.
Thank you so much for an amazing talk and very practical talk. Importance of starting early during discharge and titrating up quickly. I wanted to know how the UCLA Heart Failure Clinic is handling patients who, there are a lot of patients who get discharged from non-cardiology services that have low EFs. And I wanted to know what the strategy is, whether it's NP-based, every 2 weeks follow-up, whether it's telehealth, whether it's pharmacist-based. What is your approach at UCLA?
Yeah, I appreciate that. So it's evolving. We were, for our patients that are in the heart failure program and seen in the cardiomyopathy center, we provide that full gold ticket advanced practice nurse, telephone calls, telemanagement, visits, video visits, everything in the up titration proceeds beautifully. To scale that up across our whole health system, that was challenging. We have tried the model where patients enter just the 12-week phase to where PharmD advanced practice nurse working under the supervision of a heart failure cardiologist will engage that patient, make recommendations, and can use standardized order sets to do some of the up titration, and that has worked well. We have not been able to scale that up outside of Westwood, though, to our other community-based practices. There, we're looking at more of a digital strategy where those patients enter, and then there's a series of prompts that are put out to the clinician in a heart failure dashboard, and where we highlight, what percentage of patients are on quadruple therapy. And then to the credit of my Owen Fogelman, who was the division chief and carried by Dale Abel for Department of Medicine, I should say, Department of Medicine chief, created a financial incentive program for our cardiologists to actually achieve GDMT in these patients. We just published it where serious dollars were being offered to offset the time and otherwise additive, not punitive. And it really, it had a pretty substantial effect on our use of GDMT. So there are different models there. I think, we're seeing an evolution. I've been involved in a couple trials. There was one recently published that was done at Cedars-Sinai, where they used a digital AI assistant to the clinician that helped achieve up titration pretty rapidly. So I think we're going to see, hopefully, as there's more focus on this, new innovation to make it, scalable, sustainable, and that all patients within the health system can derive these benefits.
Thank you.
Thank you. Any other questions? Well, it's 8:37. With this, I think we can wrap up. Again, I want to thank you very, very much. This was absolutely amazing. Fantastic talk. Very great company. Hopefully next time we'll bring you in person. Thank you very much for your time today. And thank you everybody for joining. And we'll see you next time.
The preceding program is copyrighted by Emory University.